little past 12 and we've got a good group of people here, so we'll go ahead and get rolling today with our next HED Talk. So we have Dr. Wilbanks here giving a HED Talk on identifying the antisocial female. Dr. Wilbanks is a forensic psychiatrist at the Arkansas State Hospital, and she's one of the residents' favorite educators here at UAMS. I heard Dr. Wilbanks give some of this material at last year's Arkansas Psychiatric Society meeting, and it was excellent, and I'm looking forward to another refresher here of this topic. I think you all will very much enjoy this, and with that, we'll give the floor over to Dr. Wilbanks.
All right, thank you all. I'm going to share my screen. And give me just a second. There you go. So you can see the hopefully the correct the correct screen. That's always the awkward part of Zoom, isn't it? And I'm, elderly enough at this point that I always ask, can you hear me and can you see me? Still, but yeah, so thank you guys for joining me to learn more about antisocial females. I like to consider myself the ultimate feminist. So, I think women are just as good as men at everything, but women can also be just as bad as men. And I think we often don't like to think that when you think about, little tiny girl that can't do anything bad. So my goal for you all with this talk is for you to be hopefully feel more comfortable giving this diagnosis to women that you come across. And yeah, this is a little bit of a different, somewhat different lecture, though my jokes may still be the same, Dr. Burrows. So even though you've heard part of this, laugh along. But I do like to typically go into a historical example of antisocial females, but we don't have time for that today. So if anybody wants a true crime discussion, come find me later and we'll talk. So you will hopefully hear me throughout this lecture kind of tell you my goal is not that, women have the same rates as men with antisocial personality disorder, but I do think that it is underdiagnosed. But currently with the I guess most recent literature that we have, and then also listed in the DSM-5, we know that antisocial personality disorder is 3 times as common in men than in women. A little bit more about those prevalence rates. These are a few of our different landmark epidemiological studies in the US, and we see that the lifetime prevalence of antisocial personality disorder was 2.5%, 3.5%, 3.6%. So that's kind of the general prevalence. Hasn't changed much over the years. Definitely note that the ECA and the NCS uses the DSM-3, so those are older studies, and then the DSM-4 and the National Epidemiological Survey on Alcohol-Related Conditions. One thing I also want to note is, again, here males have a higher prevalence of antisocial personality disorder than females. Specifically looking at the NCS, males have a prevalence of 5.8% compared to females at 1.2%, and that's about 5 times higher. But if you get into the later study in 2005, males have 5.5% prevalence and females almost 2%. So we're closing that gap a little bit, and that's where you get the 3 times more likely in males versus females. Compared to the general population, we all know that antisocial personality disorder is more common in prison. This is a systematic review of prisons worldwide that showed 47% of male prisoners and 21% of female prisoners have antisocial personality disorder. And for you more visual learners, I've included this forest plot so you can see, where the male prisoners are here and female prisoners are here with the higher rates of antisocial personality disorder. And one of the critiques of the current DSM criteria for antisocial personality disorder is that it focuses on easily measured behavioral criteria, which is meant to improve our diagnostic reliability, but that may lead to an overdiagnosis in criminals and then an underdiagnosis in the general population in either sex. Okay, so we've determined the rates are different in males versus females, but why is that? Well, there may be a legitimate difference, which I think is partly the case. Again, I do still think that it is more common in men personally than in women. And you know that goes with a lot of different things, that there are legitimate differences in men and women. You know, you don't have men with you know, postpartum psychosis very often and things like that. So so there are biological differences. However, there could also be some bias that we're you know, missing antisocial personality disorder in females. So again, I don't think that it should be equal in males and females, but I think it's possible that we're missing it due to gender biases. So where might those biases exist? Many areas, but the one that I want to focus on is our application of the diagnostic criteria, which has the most empirical support and is also something that I think we as individuals can more immediately change. Clinicians, because we're human, have our own biases, your own internal biases. Also, we favor giving diagnoses to those that it may be more common in. So in medical school, they often tell you that, you know, always remember it's more likely to be a horse and not a zebra. So we're going to favor giving females the histrionic and borderline personality disorder diagnoses and males the antisocial and narcissistic personality disorder diagnoses. And I think, or I hope, it's less about your gender biases and more, you know, related to the fact that we're thinking about prevalence rates in these populations and is why we may be missing antisocial personality disorder in women. But I really think that that can get us into a vicious cycle. So I can't really do anything about your own internal biases, but what I can, again, focus on you know, is kind of getting you to think more about the diagnostic criteria rather than, well, what is more likely based on prevalence. A little bit more about clinician biases because I found this study pretty fascinating. So again, you know, clinician bias exists. We're human, and this study was in 2004 of 167 psychologists. And they were to read two different cases and provide symptom ratings and diagnose them. One case was the target case, which was meant to be antisocial personality disorder. And the other was a mixed personality disorder or personality disorder NOS to divert focus away from that case of interest. So they're asked to assign diagnoses, and you'll see that the majority of people, I'll kind of point out here, majority of people overall, 53%, correctly diagnosed antisocial personality disorder. And while this wasn't statistically significant, you can see that they got it more correct if the person in that case was a male version. So still, you know, got it correct 46% in females, but you know, almost 61% in the male version. Now, interestingly, the thing that was statistically significant was that the female version was more likely to be misdiagnosed as borderline personality disorder. And I'm going to talk more about that in some upcoming slides about that misdiagnosis and perhaps comorbidity. So regarding the diagnostic criteria of antisocial personality disorder, I'm not going to talk about these because hopefully you are somewhat familiar with the DSM criteria. But there are differences between men and women regarding which criteria they most often endorse. Men with antisocial are more likely to endorse that failure to conform to social norms with respect to lawful behaviors. Irritability and aggressiveness, and then that reckless disregard for safety of self and others. So kind of more like overt, aggressive and active things. Whereas women with antisocial personality disorder, they're more likely to endorse deceitfulness and impulsivity or failure to plan ahead. There was no difference between the mean number of criteria between the two sexes. So I want to further illustrate some of these differences between the criteria most likely expressed between the two sexes, and primarily with how they get their needs met. So antisocial men most often will use verbal or physical aggression to get what they want or meet a certain goal. And antisocial women are more likely to be manipulative and even use flirtation and promiscuity to meet their needs. So some of the literature will discuss that antisocial women are higher in that promiscuity trait than antisocial men. I kind of or that's kind of a criterion in which we can tell, like, oh, this woman is more antisocial than anything else. I kind of disagree with this. I think it's it's kind of older literature, but also it's just more socially acceptable for their male counterparts to be more promiscuous. So it's not really noted as a trait of psychopathy or antisocial personality, but it is in women when they have multiple sexual partners. So yeah, I have my thoughts there, but regardless, just kind of remember that in how they get their needs met, men are more likely to be aggressive about it, and women are more likely to flirt and be manipulative to get what they want. So multiple studies show that female psychopaths show that they're more emotionally vile and impulsive. Of course, women, we have this wandering uterus that floats all over our body and into our brain and causes us mass hysteria. So those of you who don't know me, that was sarcasm. But the females with psychopathy or antisocial are more emotionally unstable. And then psychopathic men tend to be more self-aggrandizing, self-centered, and domineering. So perhaps due to this emotionality, women with antisocial may appear genuinely or otherwise more empathetic. If they can kind of better fool others into thinking that they have a genuine, fond emotion. They can even sometimes come across as caring or maternal when that's not exactly genuine. On the other hand, it may also make them appear more or have more anxiety and depression. Thus, they will often have more comorbidities in this area, which we'll talk about next. So comorbidities among females with antisocial personality disorder, the more common ones are major depressive disorder, dysthymia, and then your anxiety disorders like panic, specific phobia, PTSD, and generalized anxiety. And then male antisocials are more likely to have comorbidities with alcohol use disorder and dependence, old terminology here, and then any drug use disorder and narcissistic personality disorder. Their antisocial females also have higher rates of comorbid borderline personality disorder and histrionic personality disorder, which I highlighted those rates in this table here between men and women. So and among female prisoners, the highest comorbidity rate was among the antisocial and borderline personality disorder, with 43% of women with antisocial also meeting criteria for borderline personality disorder. And this is something that I think can really cloudy that diagnostic picture, and one of my big arguments. So too often we will see a female behaving badly or impulsively, and we automatically will diagnose borderline personality disorder and completely look over antisocial personality disorder. Again, they have a lot of overlap, but I do think it is very important to determine which one is primary and which one kind of influences their behaviors more. So what if they have both? Like we see here, 43% have both in the prison population, and I think it's then going to cloudy this diagnostic picture more, and people will solely get diagnosed with borderline personality and completely disregard that antisocial personality. So again, I think can be detrimental to potentially the safety of others, and also safety of self, if you miss that antisocial diagnosis in women. So kind of related to borderline personality disorder, we're going to talk about an increased risk of SI and self-harm. So psychopathy in females has been linked to more self-directed violence. Let me first discuss very briefly the hair psychopathy checklist, which I have the short version items listed here. So it's a 12-item checklist in the short version. Often it is separated into these two separate factors, with factor 1 representing more of the interpersonal affective traits of psychopathy, and factor 2 representing more of the impulsive antisocial behaviors. So this study showed that women with higher psychopathy traits have an increased risk of both comorbid borderline personality disorder and SI and self-harm. Interestingly, the male psychopaths who scored higher on this factor 1 interpersonal affective traits, it was almost protective against suicidality. So why isn't that the case in females? Why did they only see that in males? And they think it's probably best explained by gender-based socialization and just kind of the social norms, whereas women tend to internalize feelings and are taught by society to not act on aggressive thoughts against others, but it's more socially acceptable for men to physically fight than females. So women start internalizing it more and have increased rates of anxiety and depression, like I've already mentioned. So I don't want you to get the impression that women with antisocial personality disorder are not aggressive. They can be aggressive. When they are, it is primarily against close intimates, like their significant others or their children. And because of that, it's going to be less likely to be detected by the justice system. They're not, outside of the home, often very violent. Also, they tend to have more of that covert violence where they spread rumors or gossip about somebody or somehow try to ruin their reputation. This was supported in Warren's study of 261 female felons in a max security prison. She found that the antisocial women had a higher rate of self-reported violent behaviors within the institution, but did not have similar rates for violent rule infractions. So this suggests that they have an ability to kind of manifest a covert violence that doesn't result in institutional action. And so it kind of happens more under the table. Of course, it's also possible that they exaggerated or embellished their exploitative tendencies, or, most likely both. What I have noticed in treating antisocial females is that they kind of do more of that gossiping and under the table violence where they'll pit one patient against another patient on the unit and kind of, maybe lie and deceive them and make them then fight each other on the unit. So while they were not the ones being violent and aggressive, they instigated violence and aggression, and they kind of sit back and watch the chaos that they caused. So so again, women with antisocial can still be aggressive, but they're probably going to be a little bit sneakier about it. So similar to borderline personality disorder, antisocial patients have a high rate of trauma. Males tend to report higher physical abuse and female sexual abuse. This data is from that National Epidemiological Center of Alcohol and Related Conditions. So they studied 43,000 civilians, but the antisocial population is what's listed here. And this table is busy, I know, but it's just here to illustrate how the vast majority of areas of adverse events, so childhood adverse events, parent-related issues, adult adverse events, women with antisocial personality disorder are more likely to report these abuses than men with antisocial personality disorder. And then let me talk a little bit about psychopathy. So, kind of more of an extreme version of antisocial personality disorder. One of the big questions in the literature is, can you use that hair psychopathy checklist to assess for psychopathy in women when most of the data from this assessment was primarily focused on men? So can we automatically say that you can apply this in women and that the scores will be valid in women? Possibly not. So this study showed that women do have lower psychopathy scores than men. This table right here that you're looking at is a community sample. So none of them should be meeting psychopathy threshold, which for the PCL short version is 18, and then the PCL-R is 30. So again, we're not talking about a big group of psychopaths here, but you can still see where the women are scoring lower than men. This next table is the psychiatric population, with the almost half, first half is your civil psychiatric population. Again, should not have many psychopaths there. And then your forensic psychiatric population, where you should be seeing a little bit closer to psychopathy scores there. Again, men are scoring higher than women. But I do want to point out in this forensic population, let me get my little thing. The differences between men and women are not statistically significant. So that tells me personally that we should be seeing more psychopathy scores in that group, and there shouldn't be any difference there in using the psychopathy checklist in men and women. Some people have suggested, because of data like this, that perhaps we should lower the threshold or the cutoff score for women in order to diagnose psychopathy. And to me, this just tells us that that's not really necessary. So much like I described the differences between the antisocial personality disorder criteria, DCM criteria, there are items on that psychopathy checklist that discriminate between male and female antisocials. So men scored higher or more often scored with that callousness and lack of empathy, as well as juvenile delinquency. And then women were scoring higher on promiscuous sexual behavior, which I already provided my personal comments on that. So let's look at the psychopathy traits a little differently using that factor 1 and factor 2 model that I showed earlier. So hopefully by now you're kind of getting the picture. And since I don't have anybody in person, I can't ask you, which do you think, which factor 1 or 2 do you think is more common in women and which in men? But as you can hopefully expect by now, factor 1, that interpersonal affective group of criteria is women are gonna score higher on those, whereas men are scoring higher on the factor 2 antisocial behaviors. So why do we care about psychopathy scores? Why do those even matter? Well, it can be a good tool to help us predict future violence. It does so in men. So does it do that in women? And yes, it seems so. So the PCLR was an effective predictor of reconviction with little difference between men and women. And then the PCL short version was also a valid predictor of reconviction and violence with no difference in its efficacy in comparison to men. So too long, didn't read. What do I want you to really take home from this lecture? So one, I do think that antisocial personality disorder is underdiagnosed in females, though I don't think it should be equally diagnosed in women and in men. Female antisocials tend to be more deceitful, lying, and manipulative, as well as more emotional and impulsive. They tend to exhibit more covert aggression than overt aggression. They do have higher rates of comorbid borderline personality disorder, but do not let that confuse the diagnostic picture, and don't, see that they meet criteria for borderline personality disorder and, just completely gloss over an assessment of if they have antisocial personality disorder, because they could have both. They do have a higher trauma history, and then that psychopathy checklist can still adequately capture psychopathy and predict future offending. I have a bunch of references there, and will eventually end my slideshow and then answer questions.
Thank you, Dr. Wilbanks. That was awesome. So now we've got a little bit of time to answer questions and ask questions. I'll get us started here, and if anyone has questions in the chat or wants to ask, I can help facilitate those. But my first question is, I think you did a really good job, showing the differences, and in particular, one of the differences that I see personally, especially on the inpatient psychiatry unit at times, is the difference in that aggression piece. Males with antisocial personality disorder, you will often see them displaying physical violence on the inpatient unit, with their peers, with other staff. And then, females with antisocial personality disorder, it kind of goes under the radar. They may be gossiping about other staff or peers behind their back, destroying reputation, but it goes under the radar. And so my question is, for you personally in your own practice, working at the state hospital, and even, for us residents out, in the community doing clinics and things, are there a particular screener or sets of questions that you ask that are helpful to elicit kind of some of these more hidden and undercover female antisocial personality disorder criteria that, we can't see as clearly? How do you elicit those?
That's a good question. So, I think it's still important. This actually is kind of related to I think Tim Taylor's question about like when does antisocial personality disorder present. So to get that diagnosis, you have to show conduct disorder behavior before age 15. So I do think it is important to still ask, on admission, how did you do in school? Did you get in trouble a lot in school? Were you using drugs at a young age? Were you, again, being promiscuous at a young age? Again, for males and females, and then asking them, your first contact with the legal system. If they have that conduct disorder stuff or a history of violence, then that's going to be pretty indicative of them. Of course, past history will predict your future more than anything. And so I think that's probably the best as far as like screening questions. I think with more often with my females on the unit that I end up diagnosing antisocial personality, it takes me a while to figure it out. I don't really notice it on admission because again, they have that emotionality and they know to kind of, let me talk about my kids and how much I love my kids. And so, it can kind of fool you into thinking like, oh, they're just a good mother. But then later you kind of see a pattern of behavior and come to find out they only say they like their kids because they know that is what they're supposed to say. They lost custody of their kids a long time ago and they've never cared for their kids. And so they've never been there before. What's different now? And that can kind of tell you. So maybe that's another screening question, like, do you have custody of your kids and why did you lose custody? But again, I think maybe more so with women than men, it takes a little while to get to know them and get to know their underlying drives.
Thank you. Yeah, no, that was helpful. Yeah. So, I mean, it sounds like, since they are so hidden, you kind of just need more time and, diagnostic clarity just to get more data points over time, essentially, and from their past history too,
Mm-hmm.
it sounds like.
Yeah. I think, ideally you get, you need to have an extended period of time with a patient to give a personality disorder diagnosis, kind of notice a pattern. In forensics, doing forensic evaluations, when you see a person for 2 hours, 3 hours, you have to be comfortable with giving a personality disorder diagnosis, not really like having that much time with them. So I feel more comfortable than maybe general, psychiatrists at doing that. But.
Well, thank you. And so you answered, I think, part of Tim's question in the chat, but Tim Taylor asked, at what age do people begin displaying symptoms of antisocial personality disorder?
Mm-hmm. So it does tend to be, it should be before age 15 that they have those behavioral problems. So you just start noticing conduct disorder. You can't get a diagnosis of antisocial personality disorder until they turn 18. And then typically it's that like 20-year-old that you'll really notice those antisocial, particularly aggressive symptoms because they're young and dumb and do things impulsively and start fighting and, think they're invincible. Antisocial personality in general tends to kind of decline with age, and I think we don't really know why. Is it because they're dead because they're doing such like impulsive, dangerous things, or is it because they're getting older and they can't be as physically aggressive? They're going to be like attacked by the younger antisocial now, so they're they just kind of get tired and don't display those symptoms. So yeah, you should really notice like traits as, for conduct disorder, and then like their 20s is when you're going to have like high rates of those symptoms showing up.
And then it looks like Matt Boone asked, and then Dr. Crane has a question too. It looks like, are there effective treatments for antisocial personality disorder?
So I'm going to say in short, no. For the shortest answer, you will often hear people kind of snarkily say that like the best treatment for antisocial personality disorder is incarceration. And that's big. I mean, kind of snarky, but like kind of true. Like they need to have consequences for their actions so that they learn to not behave aggressively or deceitfully or whatever. As far as like if they have comorbid depression or any sort of comorbidities, you want to treat that. Now, we often will give various medications, SSRIs, antipsychotics to dampen their aggressive impulses. What else? Group therapy is pretty contraindicated in antisocials because they will start kind of preying on the other group members, especially those that are kind of weaker than them in whatever way. So yeah, that's kind of the long answer.
And Dr. Crane, did I see you raise your hand?
Yeah, well, I just wanted to pitch in on that issue of like, where are these folks when they're older, doing Jerry psych, and that we used to say that personality disorders like sort of burn out in late life, and we're not saying that anymore. But I think what happens with antisocials, they also they tend not to engage very well in primary care, and in combination with their risky behaviors. So they don't get their cancer follow-ups, they don't get their blood pressure. And so I think they also are not making it into late life because their medical issues are catching up with them in their 60s and 70s, where a lot of other folks are living on.
All right, everybody. Well, it looks like we're past 12:30. So thank you all for being here. And thank you so much, Dr. Wilbanks, for this interesting topic. We've got this recorded. And so Tim and I will work on uploading this to the UAMS YouTube page. So thank you all, and you all have a great rest of your day, and stay safe out there in the cold weather we're having.
All right. Thank you.